Hello, everyone. My name is M Oddo. I'm from the Department of Intensive Care Medicine in Lausanne, Switzerland. Well, first of all, welcome to this ISICEM 2020, and thanks for the invitation. And thank you all for attending this session, which will be on the issue related to pressors, vasopressors versus fluids. What is the right balance? I don't have any conflict of interest related to this presentation. Why are we discussing about this topic? Well, I tried to summarize the treatments that are often employed in patients with acute brain injury in the ICU. And you would agree when I say that vasopressors and fluids are basically used in many patients in the ICU and are probably the most employed therapies that we apply to patients with brain injury. I listed additional treatments that we usually use. And again, vasopressors and fluids, probably all patients will receive these two therapies. So the question always in this setting is whether I should raise vasopressors or whether I should deliver fluids. And actually, often we combine both therapies. And the thing here is not only which of the two, but how many. So what is the optimal amount? If we go back to the pathophysiology, the question behind, the rationale behind the use of vasopressors is to improve, to increase, and in terms of optimizing, individualizing the best perfusion pressure in our patient. And why do we do this? Because the equation that I summarize here, the cerebral blood flow, is highly dependent on cerebral perfusion pressure, which is the driving pressure. And cerebral perfusion pressure, please recall the fact that it's not a variable that we measure, it's a variable that we calculate based on the measurement of mean arterial pressure, which must be done invasively, and the measurement of intracranial pressure, which also must be done invasively, which highlights the importance in patients with severe brain injury to monitor intracranial pressure invasively. So if cerebral perfusion pressure is the driving pressure, then if you want to improve cerebral blood flow, if you want to optimize flow, avoid or prevent ischemia, you definitely want to raise CPP, and raising CPP is mainly by raising mean arterial pressure with the use of vasopressor. The vasopressors you can use are generally norepinephrine, which is the vasopressor that has been mostly studied in clinical but also in experimental studies. Secondly, you have phenylephrine, which has the advantage of being a pure alpha agonist. So if you raise norepinephrine too much, you can have the beta agonist, which may be a disadvantage. You can also raise flow by combining vasopressor with inotropes, like, for example, milrinone, which has the advantage of being an inodilator, so you can improve cardiac output and improve cerebral blood flow. What you see here, going back to vasopressors, is measurement of CBF, volume, and the amount of ischemic brain volume using PET scan. These are patients with severe traumatic brain injury. And you see on the left part of the screen that by raising cerebral perfusion pressure with norepinephrine and going from 65 to 85, you actually indeed raise cerebral blood flow. You increase volume, so you dilate vessel. And in patients like this one, it means that if you have an impaired autoregulation, this may translate into increased ICP, so you must be careful. especially if autoregulation is impaired. But these are the patients you want to raise pressure to avoid ischemia. And what you see on the right part of the screen is that the amount of ischemic brain volume measured with the PET scan is actually reduced. So by raising blood pressure with the use of vasopressor, you may improve flow, you may reduce ischemia, and this is particularly true in patients who have impaired autoregulation, who are at risk of secondary ischemia. The second example is in patients with severe subarachnoid hemorrhage. And here you have measurement of cerebral blood flow using a regional device monitoring coupled with brain tissue oxygen. And again, this was induced hypertension alone and separating the effect of vasopressor from fluid. So on the first H, the famous, what we called in the past triple H, the first H is the induced hypertension alone using vasopressor, increasing blood pressure with norepinephrine. And you see that again, you raise regional cerebral blood flow in pink, and you improve brain tissue oxygen, which means that there is an advantage for the tissue. On the contrary, if you use fluids, and in this case, this was mostly by using colloids, you hemodilute, you don't have any significant effect on CBF, and you actually have a reduction in brain tissue oxygen, probably because you have hemodilution, you reduce hemoglobin, and therefore you reduce brain tissue oxygen. So this is a clinical study showing the benefit of pressures and not a benefit on fluid. Why? Because again, cerebral blood flow is mostly dependent on the driving pressure, therefore on the cerebral perfusion pressure. And this is the reason why pressure are mostly used, and you should not use fluids if the rationale is to improve cerebral blood flow. So we should move from the triple H paradigm to the induced hypertension paradigm, and adding, of course, normal volemia, and even in some way transfusing the patients to improve hemoglobin. To improve flow. So you must use more pressures and less fluids. The problem, the downside of using vasopressors is that you have the vicious circle that you all know. We all know that by increasing vasopressors, you have what we can summarize as pressure-induced diuresis. So you put the kidney under pressure, and these can become then complicated because you have polyuria, and then you have to give fluid to the patient. You have problems with sodium and osmolarity, and you end up with a vicious circle. Now, when you look the recommendations, and these are the most recent recommendations based on the intracranial pressure monitoring consensus conference that was recently published in Intensive Care Medicine, you see that to to improve blood flow and to optimize mean arterial pressure and CPP, you do what we call the mean arterial pressure challenges. So you raise blood pressure, mean arterial pressure by around 10 millimeter of mercury, and then you monitor what is going on. You can actually test autoregulation, see whether if you raise blood pressure, ICP goes down, this is normal autoregulation. If it goes up, well, of course, you have loss of autoregulation, so you must balance pressures with intracranial pressure. And on the other extent, another variable that you can monitor invasively is brain tissue oxygen, and see whether by raising mean arterial pressure you have an improvement in brain tissue oxygen, as we saw in the previous study. And you see that always in this recommendation you have vasopressors and fluid boluses, some amounts of inotropes. And again, this is highly dependent on to whether autoregulation is preserved or impaired. And one way to measure autoregulation at the bedside is by actually seeing the interaction between intracranial pressure and mean arterial pressure. You can use the pressure autoregulation index, or you can just check at the bedside. If you raise mean arterial pressure and intracranial pressure goes up, it means that the patient has impaired autoregulation, so you must be careful in titrating blood pressure. If the general paradigm in preserved autoregulation is that if you raise mean arterial pressure, then ICP actually goes down because you vasoconstrict, and so reduce volume and you reduce pressure. So basically, this can be tested at the bedside, and probably in patients with preserved autoregulation, the level of blood pressure can be raised more than in patients with impaired autoregulation. And another way to test this at the bedside is by integrating CPP with brain tissue oxygen. Raising blood pressure, cerebral perfusion pressure translates into improved brain oxygen, and this you can do it at the bedside. So basically, to summarize, I think again that vasopressors are the main driver, but of course you need to resuscitate patients with fluid. We use fluids daily, and we use a large amount of fluids. The main point here is that you must use isotonic, or when it becomes more complex because of the pressure-induced diuresis phenomenon, you should switch and use more hypertonic fluids. And I would refer to this very nice review by Mathieu Legrand and Romain Sonneville, published in Intensive Care Medicine, which summarizes the fact that we should reduce the amount of fluid by using hypertonic fluids, especially in conditions where sodium and osmolarity are below the normal range. So in conclusion, yes, for vasopressors, it's more vasopressor to optimize CPP, to individualized therapy coupled with ICP and brain tissue oxygen monitor to optimize flow, less fluids, and double check tonicity, osmolarity, and natremia, fluid balance, check ICP, and use as much as you can isotonic or hypertonic fluids. Thank you very much for your